appreciate y'all coming on a Saturday and on Final Four Saturday, nonetheless. We're going to talk about what we do, how we advance hip arthroscopy in this region, and how we can make it better for our patients. This is a conversation, so I'm not lecturing y'all. We'll do a surgical demonstration. After that, we're talking, okay? So I want this to be an exchange of the minds. Sound fair? Everybody got that? Say yeah. Yeah. That's better. All right, next slide. Let's talk about the impact of what we do, okay? So we all know that it's so much more than physical when it comes to injuries, sports injuries of the hip or anywhere else, yeah? And so I think what our team is most proud of is what we've seen as it pertains to the patient's global health. So our internal outcomes data has shown us an astronomical skyrocketing of the patient's global mental health after hips are fixed, okay? And we know that the hips are integral to everything we do in life, right? You can't do anything without a hinged hip. Can't sit, can't socialize, can't walk, can't play with your kids, can't do sports. And so this makes sense. I think it tracks. So on account of that, we've been very proud to be named the top 1% in the nation as it pertains to hip and knee. And that's not us, that's all y'all in the audience, because I see them for like an hour and a half, and then y'all do the work for months. So give yourself a round of applause, please. All right, so if there's 3 take-home points I can give to you, I know this is against my best interest, but just because it's torn does not mean I have to fix it. Just because it's torn does not mean I have to fix it. All labral tears do not have to be fixed. Most of them don't need to be fixed. And I think like 60% of my clinic is sending away patients who have labral tears and say, "Doc, you gotta fix it, you gotta fix it." Like, no, have you been to physical therapy? Oh, physical therapy doesn't work. Let's do some ammo. Let's talk about why this is gonna work. So this is what people want. "Doc, my labrum's torn. I want you to do that thing you do where you put the anchors in and you stitch it up, and then I go about my business and never think about my hip again." First off, I'm not that good. Nobody is. So you're not gonna be the same after surgery. I can fix it as pretty as I want. All right, so that's number 1. Number 2, surgery should always be a last resort. Y'all know this. I'm teaching to the crowd, right? Speaking to the church. So let's go to the next slide. This is what we need to do. Empower patients to heal themselves. So let's take a step back and think about why a labral tear hurts. A lot of patients are under the impression, oh, my labrum's torn, that's why it hurts. Okay, but it's bigger than that. It's a question of stability of the hip joint, okay? You all know the labrum here in pretty blue in this picture is a suction seal on the joint, okay? So when torn away from the acetabulum, like it usually is, you lose the suction seal on the joint. Patients have micro instability. It bothers some patients more than it bothers other patients, yeah? Those patients who it does not bother are able to compensate through it. So we need to empower patients to understand this picture more than this picture. Strengthening of the abductors, the core stabilizers of the hip, dynamic stabilizers. Get those as strong as possible, all right? And you might never have to see me again. Now, even if you end up having surgery, if all that fails, you're gonna come out way stronger on the back end, all right? So it's a win-win-win-win-win. So number 1 point is that most of them don't need surgery. We only do surgery if we have to. Now, if we're gonna do surgery, I'm gonna do it right. Next slide. So let's talk about how we do that. So hip arthroscopy has gotten a bad rap amongst some because I don't think it's always done to the level we want it done, respectfully, okay? So there's a certain respect we have to have for the hip itself. And I think previously there was a notion among surgeons that the hip is so stable, it doesn't matter what you do to it, it's gonna be fine. Not true. This study, 10 years of follow-up, came out recently, just last year, showed that for those who had hip arthroscopy, if the labrum is not correctly treated, i.e. debrided rather than fixed, or if the hip capsule, y'all familiar with that, is not fixed at the end of surgery, that patient's risk for going on to a total hip goes up astronomically. 1 out of 3 of those patients end up with a total hip. So the details matter. We have to respect the hip, just like we respect all the rest of the joints. You wouldn't go out and just shave out somebody's meniscus. You wouldn't go take out somebody's ACL. So why'd I take out a stabilizer of your hip? Makes no sense. So I want to give a shout out to Mr. Ronnie Shaban in the back. He's representing Stryker Sports Medicine. And the shout out is because he's our partner in the OR. He helps us get things done. But the product that Stryker provides us has changed the way we do hip arthroscopy. So the hip is one of the most congruent joints. So getting into it is a journey, to say the least. So here's an x-ray from inside surgery. Let me use the laser here. Here's an x-ray from inside surgery, okay? So in surgery, we're pulling traction on the hip to create space in the joint to let us get in and do our work, okay? Historically, we have done this by pulling against a post by which the patient's leg is pulled against it, and that's used to get distraction. As you can imagine, some people had some complications from that, right? And that's a bad thing. Doc, I had some pain in my hip before, now I can't pee. That's not a good trade-off, yeah? So, Stryker developed the first postless system by which we use a combination of friction and gravity to get the hip out gently and safely. And we were the first at Ortho Virginia to use that for hip arthroscopy, and now we're the ones using it the most. And so that has changed the face of hip arthroscopy dramatically. We've seen the difference. Hit one more. I got some cute little animations. Yeah, one more. There it is. All right. So let's talk about the hip capsule. The hip capsule is not one thing. The hip capsule is a group of ligaments coming together. It's a structure, it's a complex, okay? And so these are ligaments. The iliofemoral ligament is here in the front. The ischiofemoral ligament is around the back, not in this picture. The pubofemoral ligament is down here. The zona orbicularis is down here. All that comes together to form your capsule. So it's a complex. It's not just the structure. It's a bunch of ligaments. And like I said before, you wouldn't just go cut a ligament elsewise and think everything's going to be okay. No? Go next slide. So one of the keys to successful hip arthroscopy is appropriate capsular management. Capsular management is the name of the game. When we do our surgical demonstration in about 2 minutes, we're going to go over all that. But just to give you some orientation. I think my laser's dying. So the hip joint is here. The capsule goes around as kind of a saran wrap to hold things in place. To get in, we do what's called a capsulotomy, make a cut across the capsule to do our work. Now, we want to make this as small as humanly possible to do our work, because even if I close it at the end, again, we're just human. It's not perfect. As little impact as possible to those ligaments. One strategy we use to do that is to keep it small and then put special stitches in, traction stitches, to retract it out of the way so I can make it smaller but still get to where I need to get to with a smaller cut. That makes sense? You're going to see this in the video, but I thought maybe some still shots would help. This is a special suture passing device made by Stryker Sports Medicine, and basically it patches these stitches into the capsule around the labrum. We then pull on those stitches, and now we have access to the labrum, which is here, through a very small cut. Now closing it is an easier job. Patient has less healing to do, overall better. Don't forget the impingement. So most of the time, if I'm fixing a labrum in somebody who's young, there's some kind of impingement that caused it. All right, impingement having to do with the relationship between the femoral head and the acetabulum. So normally we have a nice smooth arc of motion. Okay, the two classically described types of impingement are cam impingement, when there's irregularities on the ball or the femoral head, or pincer, where there's irregularities on the socket. Now that's very binary. It's bigger than that. So you could have a huge cam on someone that's not bothering them because they're making it work. You could have a small cam on someone who's, say, hypermobile or has a large arc of motion, and it bothers them more. You could have someone who's retroversion. Their acetabulum is shaped such that it covers the head more, makes it so a smaller cam bothers them. So there's literally an entire matrix of things that could be causing it for a patient, all right? Their acetabular version, their femoral version, their dynamic balance, the way their gluteus activates, the size of the cam, collagen considerations. It's a million things. It's a matrix. Make sense? Any questions? Okay. Okay, so I'm calling Sherma Francis up. Sherma Francis is a physician's associate, excuse me, I almost said physical therapist.
Yeah, okay.
And she's with me in the OR. She's my right hand. Without her, none of this happens. Round of applause, please.
Hi, everyone.
So we're going to switch to the surgical demonstration video. Again, not a lecture, so please interrupt if there's questions. Sherma's going to grill me as I go along. I wonder, could we dim the lights? You think that would help? Is there a light switch right back there? Does that help? Can y'all see that better? Okay, all right. All right.
Also want to make it clear, this is the song? All right. Then if he does something and you have a question, feel free to ask. Put your hand up, I'll come get you, okay?
I do this like 3 times a week. So to me, it becomes normal, but it's different. So please ask, please ask. We are looking inside a left hip. Let me orient you because it's kind of wild. It's a left hip, the patient is lying on their back, okay? So when you're looking at them, this is the femoral head here, and this is the acetabulum back here. The labrum is coming around like this. Over back that way is going anterior medial. Coming back towards us this way is posterior lateral. Make sense? Okay, good. So we got traction at this point. We're on the Stryker Guardian table. The hip joint is out, as you can see. We're getting our initial access. We're using X-ray during surgery to localize this location. So you saw that guide pin go in, that metal pin go in. That helps us guide this cannula in. It's called a flow port cannula in this case. We then switch our camera to view from the top down to the bottom. So reorient you. Now we're going back posterior superior towards the top, okay? Going back over this way would take you back to where you were before. We usually start off with 2 of these cannulas. And one of the key important tactics with hip arthroscopy is getting multiple views. So if you try to do everything from one view, you're going to miss things. So we are constantly switching back and forth between these cannulas to make sure we're seeing it all. That's going to become apparent when we get to the labral repair. You'll see that. So again, to orient you, this right here is the capsule. All right, so we've made an initial push through the capsule with the cannula. That's not going to be enough room for us to work. So we come in with a special long-handled knife. We call it a samurai sword because we think we're cute. And we open it up to give us some space. Now, this is where decision-making comes in.
Yes. So I guess my question to Dr. L is what decision
Let's pause one time, sorry.
What decision do you make to decide what type of capsular opening do you want?
That's a great question. So, definitely not planted at all. So, so the image of the capsule cut I showed you earlier in the presentation is called a standard interportal capsulotomy. It's called that because effectively you take the knife and you cut between your 2 portals. That makes sense? Interportal. Now, in doing that, you are interacting with the iliofemoral ligament considerably. So if a patient is more unstable, they have hypermobility. They have undercoverage of the femoral head. Any other reason that gives me the willies. I'm not going to cut that fully, okay? I'm going to stop short and do what's called a periportal capsulotomy, where I just basically expand those 2 portals and then work through that.
Okay. Do you feel like, personally, when you have a patient with hypermobility and you do that process, do you feel like their PT session should be altered in the sense of slower compared to a person who doesn't go through that process?
So I think that's another great question. I think for hypermobile patients, I think there's a tendency for us to slow down just a bit. So I don't think it's about the capsular cut that's changing it for them. I think it's about their own anatomy and their baseline status that makes us want to slow down.
You're good? You can yell?
I'm fine with that.
Okay.
So when you speak of hypermobility, are you including dancers, martial arts, gymnasts? And do you mean flexibility versus hypermobility?
I'm speaking of both. Now, I'm speaking more so to, say, like a diagnosed hypermobility, like an Ehlers-Danlos syndrome or something like that. Now, for hyperflexible athletes, I will frequently treat them, even if they don't pass the test for hypermobility, as if they are, and then make the smaller cuts. Thank you. Sir?
Is there a certain cutoff on the Bateman scale that you're using as that?
That's a great question. Anybody over 5, I'm trying to do this. Very good. Everyone familiar with the Bateman scale? I'm sure y'all are. Okay, so a test for hypermobility. If I have even a second of concern when I see the patient, we do the test. And yet, over 5, I'm going to do that. Good question.
You answered my question. I was wondering if you look for that in our notes and need us to write that down, or if you do it yourself.
I would love to have it in your notes. Yeah, we can compare. Good. Sir?
One last question.
Yes, sir.
Some orthopedists seem to have a cutoff on age as to when they will repair the labral. Do you make a cutoff on age automatically, or is it patient-specific?
I think it's patient-specific. I think we have to be careful about white and black. There's always shades of gray. Now, if the patient's over 50, we're going to have a real talk. All right? We're going to basically have a talk that this might not work. You might end up with a replacement, okay? But really, my decision-making is, do you have arthritis? Okay, so, I mean, of course, intra-articularly, you're going to see loss of cartilage surface, right? But on the MRI and the radiographs, I'd have an idea beforehand. So I think it's been shown, anybody over greater than a tonus grade 1 of arthritis, that's a grade 1 arthritis, that's just a tiny bit of joint space narrowing, will not do well with a hip scope. And so you make an excellent point, because we see a lot of patients who have arthritis, but got an MRI that says, I have a labral tear. And they have trouble differentiating the two. And they say, well, doc, well, I just hurt my hip doing box jumps. I mean, it's not, the arthritis isn't causing it. I tore my labrum, just fix it. And they have a hard time differentiating me trying to tell them, but you're not going to feel better. because I can't fix the arthritis. So it's about arthritis to me. So if a 30-year-old has arthritis, I'm not scoping their hip.
Are you ever concerned about hypermobility, or are you always erring on the side of trying to maintain stability even somebody who might be kind of tight?
That's a great question. If somebody's on the tighter side, now reasons are they have that grade 1 arthritis just a little bit, or they have a very big cam, they tend to have stiffer hips, I'm more inclined to go ahead and make the full interportal cut. Now, when I fix that at the end, if I fix it anatomically, like just get the edges together but don't over tighten it, they're usually fine. That's a great question. Anything else? All right, let's keep rolling. Any thoughts, Sharma?
No, I'm good. I do have one. So for the PTs, sorry. For the PTs, if they
Let's
have
pause-
a patient,
pause one time,
pause
sorry.
one.
Yeah.
If they have a patient
Yeah.
who's in their 50s,
Yeah.
doing really well, and they do have a bit of arthritis in their joint, how should they address that if the patient is not moving forward and let the patient know? Like, what are some of the things that you want them to let the patient know at that point? Would that be in your notes so that PT knows, hey, this person has a tonus of grade 2 or 1, and they might be really slow in their progression, don't need to hit phase 3 as aggressive as you would with someone who is perfectly fine?
Okay, so this patient's had surgery.
This person had surgery.
To be clear, okay. So I think that's where we have to use the protocol, the shades of gray within it, because it has kind of guardrails is the concept. So if someone's not hitting the marks, I think we slow them down. Now that could be for a variety of reasons. Arthritis will certainly do it. Inflammation in the joint is what's going to slow them down, of course. So that's where I think we have to have kind of a team conversation where we're on the same page, telling, hey, you have some arthritis, the patient. This is going to go slower than the 18-year-old you see bouncing around at week 2. It's going to be different. You may have to kind of piecemeal this thing together. You may have to get shots once in a while, right? You're going to have days that are frankly going to suck, okay? And that's just the way it's going to be. It's different for you. So that's a great point. Cool. All right. We've shifted our view back to our initial view. So remember, again, this is going anterior medial, coming this way, posterior lateral. Remember I was talking about the capsular management. So I've made my cuts, and this is that injector, that suture passer. We're now passing those sutures into the leaflet of the cut we made so we can pull it out of the way and be able to safely get to the labrum and the rim. Now, again, this is letting me keep that cut as small as possible. The smaller the cut, the easier it is to repair. Now, you're going to see this briefly. This patient has a very nice chondral surface on their acetabulum, nice and smooth, with the exception of this little bubbling right there. When it comes back again, I'll show you. I'll pass one more stitch there. There we go. So this little bubbling right here. So this is called the wave sign. Patients tend to develop this kind of delamination of the cartilage at the edge. It's very common. I would say almost, what do you think, Sherman? 90% of people have some kind of a wave sign. So right now we're checking the labrum and we're seeing we have a separation there. We're pushing on it, we're seeing it's hypermobile, okay? So based on what we've done, based on what we described, our plan is to go ahead and fix it. We're always checking the whole chondral surface before we do anything. So looking all the way around the back of the labrum. Go back just a couple seconds for me. I want to show them one thing. Right here. This is the, yeah, go back a little bit.
Sorry.
Coming up. Pause that.
Pause right here.
There you go. This is the ligamentum teres. So it's a secondary stabilizer connecting the femoral head to the acetabulum. If someone comes in, or if I get into a person's hip and I see that's frayed or torn, I'm thinking micro-instability, hypermobility, even if they haven't tested out. So if I see that off the bat, I'm thinking I'm going to change how I manage this capsule. Makes sense. Keep going. All right, so we've established the labral tear, okay? So we're going to fix it. And I actually have, Aaron, do you mind handing out a couple of these little anchors on the table? You can keep playing. You're good. I have some examples of the Stryker Sports Medicine anchors that we put in. I'd like y'all to take a look at the tip and see how small that is. So a lot of patients will feel like, hey, I have these big screws in my hip holding my labrum in place. So that's the smallest anchor on the market. Dr. Shaban has a few back there that he can let you look at and play with if you want to. But it's only 1.4 millimeters, all right? So that's what's going in. When we first start, we're going to go and actually debride the bone on the edge of the acetabulum. And we're doing that because we want to create a nice bleeding surface for that labrum to heal back to. So we can stitch it all we want. If there's no stem cells to fix, it don't matter. Now, This is where the question about a pincer impingement would come in. Dr. Sharma?
Yeah, I was about to ask you. This is your subspine area. So do some patients have a larger subspine than others? All right, how do you decide how much you're going to shave down?
That's a great question. So that's based on preoperative imaging and the patient's exam. So Sharma, speaking of subspine impingement, wherein the area under the AIIS is a bit prominent, and that can be a secondary cause of impingement. We can call it like a variation of pincer impingement, if you like, okay? And so those patients frequently present with more so than just a straight fader. More than a regular fader, they'll have pain with straight flexion, okay? That's a lot of soccer players, that's a lot of runners. So if they independently of the normal fader exam have more of a straight flexion pain, I'm already thinking subspine. If the x-rays confirm that, MRI confirms that, then at this step, when I'm debriding the bone, that becomes more of a step. Everybody's getting some kind of debridement here for blood flow. But how much I do here depends on what the patient has. If they have a pincer, a true pincer, that's happening at this step too. This patient doesn't really have that, so this is a pretty standard. Go ahead. So we're debriding the bone there, acetabulum, getting down to kind of a bleeding bone surface, what we want to see. We want to see little trabeculae of blood coming out, and that'll make us feel like we have enough to do a repair. So this is where the anchor is going in. So there's a specialized drill guide, and so we put it into place, and we're carefully watching the cartilage to make sure the anchor is not being displaced into it as we drill. And so the drilling process goes as follows. And typically, Sharma's helping me critically at this point in time. It's a two-person job right here. So the anchor's gone in. There's a little metal inserter device that helps get into place. And then so for those of you who've seen the anchor, big difference between how it looks in here and what you're seeing in your hand. All right, so this is hyper magnified, keep that in mind. So we have the two stitches coming out of the anchor. And so I've taken to using kind of a knot tying technique where we pass stitches around and then I tie it down, utilizing knot tying, arthroscopic knot tying technique. There's also knotless options wherein you take the stitch and independently put it into an anchor. And I think this has just been better for us. So we then use a suture passer to pass that stitch around the labrum all the way around. And as Sharma can attest, we sometimes changed our
Suture style.
suture style for this. So if someone has a standard size labrum, I'm going to pass the stitch around just like this circumferentially, okay? If someone has a larger hypertrophic labrum, again, a sign of hypermobility or instability, we'll do kind of a mattress where we kind of go up and around and then inside the labrum to kind of tuck it in and have it sit as a nice suction seal on top. So we're going to do this as many times as we think we need to. That could range from 2 to 5. In some extreme cases, 6. I think that's on the extreme side. So one of the key important things here is to, as we're cutting the stitch, to push it off the articular surface. You see how I pushed the knot that way as I was finishing off? I don't want the knot sitting here in the joint causing popping and pain. Okay, so that's the key thing. So here we're going to the next anchor. We're going to do the same thing. Any questions? So again, checking the cartilage surface, making sure the anchor is not coming through. We'll also use x-ray at this step to help us make sure we see where the anchor is going. All right, so now we have our 2 stitches coming out. We'll choose 1 stitch to pass around. So once again, going up and around the labrum, coming back through. And this is something like a video game. So those of y'all who played first-person video games and what have you, I think a study recently came out saying if you play video games as a child, you make fewer mistakes in surgery. So tell my parents it was all worth it. All right, so now we've tied a nice tight knot. And if you're interested, we have some examples of the knot tying technique back over here by the table with Mr. Shaban. And he can help us, if you want to practice or see how we do it, welcome to.
I have a question for you. Clinically, is there any way you can tell if a person's anchor comes out?
Clinically, that's a great question. I would be looking for like catching and popping when they lost range of motion. That's when I'm getting nervous for that. As y'all know, that can happen anyway. If ever worried, I think just be on the safe side and have us take a look and image it. That being said, for an anchor to come out, it's kind of, that's a lot for it to come out. Something has to really, really happen. Those things are in there and they're press fit into the bone. So it's possible, but probably not a usual thing.
Kind of on that thought process, you mentioned kind of catching, popping. What are some other symptoms that may arise or that you kind of commonly, maybe not commonly, hopefully not commonly, but may signify something is wrong with the stitch or the anchor?
My biggest concern is the loss of range of motion, especially if someone is doing well and they're moving around, and then all of a sudden it's like I felt a pop and now I can't move it. Now sometimes that's just pain guarding, as you might imagine, but if that's really like a true mechanical block, definitely please let me know about that.
I would also say, just to piggyback off of that, the first 6 weeks post-surgery, patients tend to complain of that same popping feeling. And it's not necessarily that one of the anchors come out. It just might be a form of instability and trying to get stronger during that first 6-week mark. So they kind of freak out sometimes, and you have to tell them, hey, you're fine. Let's give it some more time.
There's a lot of adhesion and scar tissue too, to your point, Sharma. And sometimes what they think they're feeling is their hip grinding away, and what they're feeling is just scar tissue working itself out, be it within the joint or around the hip flexor. I think you're probably thinking, where's the hip flexor in this picture? If I do my job with the capsular cut, you shouldn't be able to see it. So it should be way back anterior medial. If I can see it, I went too far. I never see it. Let's keep going.
I got to deal with that every day.
Let's go forward. So remember I was talking about switching views and seeing the whole bit? So one can look at this and say, oh, look, we're done. We got it fixed, it's in place. But if you don't switch your view, you're going to miss critical posterior lateral extension of that labral tear. So we're about to switch our view. So once again, posterior, superior, going this way. Right here, there's some remaining separation right along here. If we don't get that, if that patient goes back to sport or some kind of impact activity, where we fixed is going to propagate along there and re-tear further. So we have to make a stopgap to stop it there. So changing view is critical to making sure we're getting everywhere and everything. So once we get there, once we change our view, same procedure. We put the drill guide into the bone of the acetabulum. We're watching the cartilage closely to make sure that we're not seeing the drill guide come out there. All right, you can see the drill a little bit better on this view, see it going through. And again, this stuff is tiny, so it looks huge on magnification, but if you've seen the anchors walking around, tiny. All right, so same procedure. We're drilling into the bone. Sherman does a magnificent job doing this. Give one last check of the cartilage, make sure I'm not seeing an anchor in the cartilage. What you can't see is she's mallazing on the outside with a little small mallet hammer, putting that in place. Stitches coming out. We're gonna do the same thing. We're gonna retrieve the stitch that we're gonna use as our leading repair stitch. And we're gonna load that into our suture passer just like you saw before. Circumferential pass around the labrum all the way around. Then we tie into place, get nice and secure. So this is excellent repair. This patient had a 3 anchor repair, nice and stable. We're now going to release traction and check our suction seal, make sure we've done what we thought we were going to do. The traction is now off. The patient is going into a more natural native state. and that's great. We have an excellent seal. Let's go on to the impingement. So like we talked about, irregularities of the bone interfere with movement of the hip. So we have x-ray helping us throughout this course of the action, but we're now sitting at the head-neck junction. So the femoral head and all the work we just did is that way, over that way. Over here, we're looking at the edge of where the ball meets the rest of the femur. And pretty soon you're gonna see we'll have an exposed cam impingement, this bump right here, see that? So we're gonna get to work with our burr, literally a little rotor looking device, and using x-ray as our guide along with our visual evaluation, we're moving along. And so the resection of the cam or the impingement is a multifactorial process. So we're using x-ray, we're using our eyes, we're moving the patient under real time, so we're watching the hip move and seeing if it still impinges when we finish. So we have a way to really know that we've done what we came to do. So this patient has a little cyst right here, you see this? So this is where some judgment comes in. If I were to keep burring right in that spot right there, I'd leave a big old hole right there, okay? So we're using our eyes, we're using x-ray, using the MRI beforehand to tell us what's what. And we know to stop short right there and take just enough. Any questions about that?
Do you ever have patients who have such a large cam impingement causing them pain without a labral tear that you go in, you like fix up the cam but don't do anything with the labrum?
That has happened very rarely. It has happened. I would say 90% of the time, what you think, Sharma? If someone has a symptomatic cam, they end up having a labral tear, even if the MRI doesn't say so. And that's another point that comes up. Any radiologists in the room? Okay. It's a frequent battle between ourselves and the radiologists. And so I might see a labral tear, they don't. Insurance takes their side over me. That's just the way it is. However, if we have a cam, a symptomatic cam, failed conservative measures and everything, we can be confident we're gonna go in and find a labral tear. So what we'll do is we'll tell the patient, we're gonna go in, we know you have a cam, equivocal about your labrum. We'll check it out, of course, when we get in, plan to deal with the cam and fix the labrum if we're there. And that's how we work around that. Anything else?
Do you do anything extra to the cyst that you see? You try and remove it, do anything at all to that cyst?
That's a great question. This is a less is more situation. So I just leave it be. It's not structural. It's not going to cause any issue. So we just leave it alone. Now, a very big cyst could require us to inject something into it to kind of fill it in. Now, that's typically, I wouldn't be doing a hip scope if it was that large. I would usually send that to, say, someone at VCU or something like that, an academic center, to get that done. Because that kind of falls along the lines of, I don't want to say cancer treatment, but like mass treatment. We don't want to go that far. Great question.
Now, sometimes patients would say, I mean, you guys can chime in, that they think their cam grew back. Do you think that's possible?
It is possible, but rare. Possible, but rare. So to fully grow back a full cam, I've seen maybe twice. Okay. Now, what can happen, though, is some patients will be inclined to create kind of sclerotic bone around the edges of where we're taking the cam off, and that can reproduce or create the impingement kind of morphology. So they're right, but they're not exactly right. Now, a couple things we do to kind of work on that, to your point. We'll use an NSAID usually after surgery to block the heterotopic ossification process, the creation of abnormal bone. We're also very careful in our soft tissue management to avoid causing excess trauma, which can lead to bone creation.
While you're working outside the capsule, do you look at the psoas to see if it's adhering to the acetabulum? Has that been an issue that you've noticed with like snapping hip or developing any adhesions anteriorly there?
That's a great question. Back when we're inside the joint, we'll look and see if there's any bruising along the psoas notch on the acetabulum. That could tell me that there might be some, as you said, impingement of the psoas. Now, it's fallen out of favor to do a psoas release. More or less, it's been shown it's not worth it to patients. But what we can do is decompress the route along which the psoas runs. And we can do that by running that radiofrequency ablation device that we use to kind of release the bone. We can actually run that into that area to kind of release the area. But we don't like to take off the psoas. That was once in vogue, but yeah, great question. All right, let's keep moving. All right, so I think Sharma can attest, this is everybody's favorite part of the surgery, watching me mow grass for 30 to 45 minutes, constantly taking x-rays. By the way, we're going to talk about coming to shadow at the end, and y'all are welcome to come, of course. Be prepared to sit for this part.
This is
So-
when most people fall asleep.
This is usually the X-ray tech's falling asleep. You gotta wake them up. So we keep smoothing out. We get to now. One clear sign that we're getting somewhere is when we start seeing this kind of pink bone. You see this right here? This is kind of the color we want to see. Now we've now switched our view. We're going to talk about the capsule closure. This is, in full disclosure, a different hip, but it's now a right hip, so we switch sides. Aaron, can you pause and go back maybe 10 seconds? All right. So in this case, the articulation is down that way, and this is our capsular cut. Does that make sense? And so we're now in the process of passing stitches across that capsular cut. Now, the reason why this has been controversial is because it's probably the most technically demanding part of the case. The reason why it's so hard is each time you're passing a stitch, you are closing yourself out of being able to see. So sequentially, you can see less and less as you're operating. And so I'm passing, this is actually my second stitch. We skipped the first one. I'm using this suture passing device, again, Stryker Medical, sports medicine, and allows us to capture the stitch. Now, what's great about this device is it's so low profile, I can get into the small corners and get to where all the capsule is. So we pass that stitch across, and then we're going to do the same thing with a second stitch. I like to alternate the colors of stitches so I know which is which, so there's no confusion. I know the black one's the black, the blue's the blue. It's the little things, y'all. It's the little things. So here we are passing the next stitch. Our goal is to get nice full thickness capsular bites when we're doing this.
So there are times that you switch your stitching style up here as well. What's the reason behind it?
Yeah, so I will sometimes use a mattress stitch, basically passing the suture from two ends of the cut and then onto the other side, almost like a baseball stitch, all right? And so it's called a mattress stitch. We call it the nasty matty. We're in the OR. We pass the stitch, and what it lets me do is for kind of a more hypomobile patient, I can advance that distal capsule forward and do kind of a plication. So that gives them a little bit more stability if I'm worried about instability. Now, this is the same arthroscopic knot tying technique we used when fixing the labrum. We're using the same instruments. Again, we have it back there if you want to take a look. And basically, we're tying that down. At this point in the case, you can't see, but the hip is in neutral extension and neutral rotation. So I know I'm not over tightening to your point. So I know that patient can get back to neutral extension because I tightened them there. So we want to see some nice watertight capsular seal when we finished. And so we move the scope around. If I can see the joint, then we're not done. At this point, I can't see any joint. We've got a good closure.
Awesome.
Good? Any questions?
Just to wrap all this up, can you stress on the importance of weight bearing post-surgery? Why is it important for 20% flat foot weight bearing?
That's an excellent question. A lot of patients, I think, have a tendency to think, I need to be non-weight bearing, or they want to do a traditional crutch, or even just put their toe down. Each of those puts more pressure on this capsular closure and the labral repair, really, than putting their foot down. And so I think we've seen the best results when us as a team are on the same page about telling the patient, I know you think you're going to mess it up, but you're actually doing more damage by keeping your leg up or toe touching. So being on the same page here helps a lot. And it's natural. It makes sense they would think that. They had a big surgery, and it's out there in the culture. You had a big surgery, don't put weight on it. All right? But I think kind of helping people to understand we're more of a functional movement kind of mentality in terms of healing and restoration, and the body wants to heal. Movement is medicine. I'm telling that to the people who know it the best, right? Movement is medicine. Put the weight down. The body needs to feel the weight and know that it's okay. Great. Anything else?
At the capsular closure phase, is there anything that you are doing differently for the hypermobile patients that you aren't doing for like standard patients?
Yeah, absolutely. So if we do the periportal capsulotomy where I don't fully connect the cut, we'll close those two portals separately. So what you saw here was a standard interportal. If you're, go back maybe 10 seconds. Maybe 10 more seconds. All right, so if I had not made a full cut, you would never have seen all the way back medially here. you would have seen a large band of tissue cutting right through there. That's the iliofemoral ligament we talked about. And so when you're doing a periportal capsulotomy, you're basically dancing around that. So for a hypermobile patient, I'm more inclined to do that. So I'm making less capsule cut, less for them to heal. Anything else?
With a hypermobile patient, are you expecting to stress more range of motion limitations in that early phase because they're more likely to maintain that flexibility?
I believe so. Now, one thing I will say is if we do the periportal capsulotomy, I found that, honestly, it's going to be hard for them to mess up their capsule closure because the cuts are so small. That being said, I think we do have to be cautious always, so we can let pain be our guide. In the very first 2 weeks, we'll maintain the same precautions, like we usually do. But with them, as you know, it's more about a functional strength restoration thing. And so getting to that functional strength of the abductors, the core, early on, and for a lot of them, they have kind of an increased pain, at least I've seen increased pain response. And so there's a tendency to not want to move, not want to strengthen, not want to put their foot down. So I think our biggest thing is actually for them looking more at their functional restoration and confidence with movement. Yeah. Sir?
Yeah. How common is it for you to see like a mixed presentation, like a cam and a pincer? And then what changes for you?
Yeah, that's great. So I would say most people are some kind of combination to some extent. And so, we're going in, we have our x-ray, of course, we'll have our MRI and sometimes CT scan to kind of evaluate that. The biggest thing that changes for me is effectively how much bone I'm going to take and where from. Now, in terms of the protocol, it doesn't change a whole lot. I will state if I do a big pincer resection, there is a tendency towards more instability because we lost some bone that we came up with. And so we might slow them down in the very beginning. Yeah. Anything else? All right, let's move on to our panel discussion. Okay, Dr. Peckham represents our brand new, fresh, off the press, Westchester office, head of physical therapy at office. Dr. Tri represents MVP physical therapy, and Dr. Mai represents Athletico, once Pivot, and will bring expertise regarding hypermobile patients. I'll let y'all go ahead and give your initial thoughts.
Hello. Is this on? Yeah. Can you hear me now? Okay. Yeah, so we, as Dr. O mentioned a lot about hypermobile patients early after surgery, the first 0 to 2 weeks. I tend to focus a lot on isometric muscle activation, kind of bracing techniques and like getting them, well trained at activating their TA, their glutes, even their quad, which helps a lot with getting them back into normalizing their gait. Sometimes they have a little more muscle inhibition in their rectus femoris from where the incisions are. So I look at if they're able to sit comfortably at the edge of the bed and fully straighten their knee on even day one. That gives me a lot of information as to how quickly I'll be able to normalize their gait and get them going with their weight bearing. If they have an inhibited quad, I might need to slow that down a little bit, let that muscle activation come back before we put more weight down through the leg. They often have other issues like in their knee, their opposite hip and knee, upper extremities, so sometimes crutch walking is difficult. And so you kind of have to work with them, be patient with them as well. So I tend to not even worry too much about the range of motion the first 2 weeks at all, just really focusing on isometrics.
Yeah. For me, similarly working a lot on isometrics. I like to get my patients into neutral in the hip, usually by week 2. So that I'm ensuring I can get the gluteals to activate well, medial quadricep to activate well. I'll look at them in weight bearing versus non-weight bearing, see if there are any issues in the midfoot that I might need to address due to a weakness in the gluteals. So if they're overly pronating in weight bearing versus non-weight bearing, is that something I need to address? I don't particularly like to do that, but I will if I feel like that might help them to activate the gluteals a little bit better. But I really focus strongly on getting gluteus maximus, gluteus medius, transverse abdominis, looking up the chain to the contralateral scapular stabilizers as well. That's kind of my initial approach.
I'll talk a little bit about my first visit. So first visit with me, we're going to talk a lot about fear and what they're afraid about, what they are afraid about going into surgery. Because like you said, they come out and they're like, I'm not even going to put any weight on it. I'm going to be fine. I'm just going to just not do anything because that hurt before. And so I focus on making sure that transfers are comfortable and they feel confident in them because they're doing that all the time throughout their entire day. We talk a lot about sleep at the front end. We talk a lot about nutrition at the front end and making sure that they're getting plenty of protein to help heal their whole system. I also try and just get them in every position that first visit so that I can see them in the position. They know what the position should feel like and is okay to feel like. We talk a lot about how it might feel the exact same as it did before surgery, and that is normal. They're like, hey, Claire, it feels the same. It feels the same. I don't know what to do. I don't think it's fixed. And I'm like, listen, let's talk about inflammation. Like, we are super inflamed the first 2 weeks. Your whole first 2 weeks, your goal is just let that thing heal. We talk a lot about the things to avoid versus the things to do. I'm like, girl, I could care less. If we are really working in here with me on getting your glutes going, you're working that at home. I'm big glutes, girl. Glutes, glutes, glutes. They hear it all day long. You're going to have a dump truck when you leave me. I try and get them to have a good contraction of the glutes in prone and a good contraction of the glutes in supine and TA the first visit. If I can just try and reinstate that, they might not even feel it that first visit, but if you're thinking about that muscle contracting, I need you to think about it. It can't just be I'm in front of the TV doing it nonstop. It is a thought. You are thinking of connecting that muscle to that pattern and reinstate that over and over. I need you to chill at home. I need you to just work on transferring correctly, walking properly, and then stairs are another thing I do the very first visit, is we work on crutching. We work on how to get up and down the stairs safely, and because they're afraid of putting 20%, what 20% looks like. Like, you can typically put a little bit more than what they think. And working on transfers and, yeah, glutes, 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 baby.
Yeah. No, that's excellent. I think the common theme, and all three of you have demonstrated phenomenal patient outcomes. And I think, and many of you all in the room, but the gluteal activation early on is absolutely critical. Now, 2 points, then I'll turn it back over to you. Societally, I think people are not utilizing their abductors. And so another 90% of my clinic is telling people who think they're strong to turn over on their side and hold their leg up. And none of them can do it. I can do it because I've been practicing. But I think there's a tendency not to use it because societally we just sit so much. So to your point, I think we're creating a reconnection for patients that didn't really exist. How do you address the patient who says, look, I'm an athlete, I've been strengthened, I don't need PT, I don't need you to show me how to do this?
I mean, you humble them day one with that exact test. I also find that they tend to compensate by coming a little bit into flexion and using TFL a whole lot. And they're like, look, man, I'm so strong. And I'm like, girl, we're going to take it 5 centimeters back. And so I show them. I say, feel the difference. Feel the difference between this. And I bring them forward just a little bit into flexion. And they can hold it. They're pretty strong. They're a runner. They run marathons. They're like, I got this. And then they come, I bring them back, and they're like, oh, okay, yeah, I don't do that. I don't do that. So I demo. And then I'm like, it's okay. You know, we're going to get a little humbled, and we're going to get really strong. You're going to come off the backside of this with such a better understanding of your body. We also talk about, especially, I work with a lot of runners, endurance athletes, the different planes of motion, which we all talk about with all of our people, and how in our day-to-day we don't do a lot of this plane here. So abduction being huge and just working on, especially if we can get them in pre-op, which you do a good job, because if they've had surgery, they've done PT before. So they usually have an understanding coming out of that of what the difference is between their glute max and their glute med, how to separate those two. And day one, I try and get a little bit of an idea of, okay, glute max, this is what we should feel. Glute med, this is what we should feel. We know the areas. I will palpate on them too, just to give them a little tactile response. Yeah, I'm a talker, so I'm going to pass.
This actually just came up in my clinic yesterday with one of my young cocky therapists, and it was so much fun to school her on it. So she had an ACL repair, and she's like, I train my glutes all the time, and I'm strong, and yet she couldn't do these basic things. She showed me, her hip abduction strength, and I'm like, that's great. Let's get you up. Let's test your hip internal rotation and sitting. She had nothing. So I think, people kind of forget how to specifically train gluteals. It's not, glute max isn't just a hip extender. Glute medius isn't just an abductor. They are rotators as well. How specific are you being when you're training these things? So that is important. I forget where I was going with that, but anyway, that was a fun lesson to teach my young PT anyway.
Yeah. And I think another thing that's important is making sure they have symmetry and strength side to side. So even if they are strong, if one side's clearly stronger than the other, that could lead to injury in the future as well. So, yeah.
Questions?
So sometimes you see patients come back with, they're working a lot on their glute and they have flexor flare up. How do you prevent that from happening?
Yeah, so
Let's get the question one more time so we can catch you.
Sorry.
no, you're good.
So at times I'll have patients come back to see me and their hip flexors are pretty flared up because they're working their glutes pretty hard. How do you prevent that in the early phase from happening?
Okay. Post-operatively, I think just like colleagues mentioned, teaching them how to transfer correctly so they're not using their hip flexors on those transfers is really big. Using the, we kind of call it the piggyback technique, using the other leg to help lift and lower and use muscle bracing techniques. Positioning as well, making sure they're in neutral or even in a little extension, just to keep the hip flexor from overfiring or being even slightly stretched, as long as it's not painful. And then, again, just managing the soft tissue sensitivity, gentle massage, different things like that to help keep it comfortable. Yeah.
For me,
Sorry, turn it off.
did you?
I think I did.
Oh, thanks. I'll bring it back to the basics. Can you perform seated hip rotation with control without any pelvic movement? Can you do a supine knee fallout without any lumbar spine movement? Can you do a quadruped rocking without overuse of upper rectus or losing your lumbar spine control? Can you do a quadruped shoulder flexion without sitting back to compensate? So just looking for, compensatory strategies and stopping those from the get-go.
I'm an education queen, so we talk a lot about in breakdown, what do we think caused that? And hopefully we don't get there, but talk a lot about how many steps are we getting? What phase of the process are we in? How strong are our glutes and stabilizers? Because I find that after 6 weeks, they feel pretty good. They look pretty good. And so they think they're good because they're this invincible athlete. And so they think that they can do all these things. I compare it to a steak, which, stay with me for a second. I compare it to a raw steak. So you go into surgery, you got this raw piece of meat. Now, these two have seared the outside, right? So it looks pretty decent. You get the brace off at 6 weeks, you feel pretty good. It looks good from the outside. It is rare in the center. It is rare in the center. So it looks fine, but you would not serve that at a retirement center. I tell them, by the end, we want a retirement center level steak. It got to be cooked all the way through. And so talking about what they're doing that they might not even think is the cause. I have a couple high schoolers who are like, yeah, I think I got 15,000 steps at practice, even though I wasn't doing anything. I was just standing and walking. And I'm like, all right, let's break that down. And so talking about cause and effect figuring out where the disconnect is. If they've gotten a flare-up, it's often a disconnect either from me or just their understanding of where they're at. And so talking them off a ledge also of like, all right, it's just inflamed. You did not re-tear. The likelihood of you re-tearing is very low. And that education on there will be ups and downs throughout that rehab process. We're in a little bit of a down. We're going to be really freaking nice to this thing. We're not going to walk too much. We're not going to overdo it with the hip flexors. You're going to get off the bike and the elliptical. We're going to peel that back a little bit. And you're going into strength mode for a little bit here. And just getting that understanding, their first flare up, they're like, it's the end of the world. It's broken. Having the education portion of, it's okay. It happens. We learned something from this. We did a little bit too much, and we're going to bring it back.
I think that point about it being nonlinear is critical. Now, I used to use the analogy, this is like the stock market. It's going to have ups and downs, but trend upwards. I don't know if I can keep saying that. But the point of patients is that it's going to be kind of sinusoidal. You have ups and downs, even 6 weeks out, even 3 months out, even a year out. And this thing is, it's a process. Matt, please go ahead. I wanted to get some of your thoughts about, the initial gait progression, especially for those hypermobile patients who have to go a little slower.
Yeah. So I think for them, really, I think getting in prone, working the glute med, even with like a TheraBand around their ankles, like pushing into it, getting them really strong. And then it takes a lot of, they have some fear, like you mentioned too, so building trust and encouraging them. But just kind of really getting to the basics with crutch walking, like step 2 gait, then step through, really teaching them what 50% is, getting them comfortable with full weight bearing on that surgically repaired leg, and just like starting with double limb stance stuff and getting really good and comfortable with muscle control there before you go into single leg stance stuff. Just taking your time and like telling them it's not like you don't have to get perfect with normalized gait by this time. Like we have a range here we're trying to get back between 6 and 8 weeks, like maybe add another week or two to your expectations on getting them back to normalized gait as long as they're not getting pain and inflammation and their quality of movement looks good. Again, with like the hypermobile patients being a little bit more restful, talking to them, educating them about positioning and posture, making sure they're not sitting up too much and making sure they're paying attention to how their hip flexors feeling, their hips feeling, if they're getting any anterior medial hip pain, and how they can reposition to offload that hip while they're resting, is really key to getting back to normalized gait, and just keeping a good balance between the glute and the quad, even getting the hamstring in there, for sure, just to just fully strengthen all around and avoid too much hip flexor active movement. They'll need it obviously for gait, but that seems to be the biggest thing that irritates their return to normal gait is if they're overusing their hip flexor. So.
I'm just going to speak to the contralateral side of that, where a lot of Dr. O's patients usually feel so good. We have to kind of talk them off the ledge of getting off their assistive device too quickly, where we have to look at function and quality of movement. Where hey, I feel great. That's great, but things are still internally healing, and you're not. You're still walking with the limp. So kind of providing that education is a key component to making sure they have good outcomes in the end.
That's a great point. So there is no stronger placebo effect than surgery. And so a lot of patients come out feeling good. They had a nerve block. They're on all these anti-inflammatories. They think, oh, doc, I'm healed. Let's go. And they're not realizing that there's a healing process that's weeks to months happening inside their hips. So your point is very important. Thank you.
Hit us with the next question. Or unless, I don't know. Do you have anything else on?
I need something from the audience.
Anything from the audience?
Well, let's talk about going from the first to the next phase. Oh, we got one right here.
You mentioned talking about steps and whatnot. Do you either give them a step goal, or are there ways for you to identify if a patient maybe he's going to take that too far, and you say, yeah, let's shoot for 12,000 steps. And like, oh, I hit 20,000 steps yesterday. And you're like, hold your horses.
Yes. And I find that it's different for everyone. So we've got an 18-year-old, let's say, we've got a 55-year-old, we've got a 30-year-old. They all had kind of a different outcome, maybe different going into surgery, and different life situations of how much they went into and how much they need to quickly. Like, let's say we've got a nurse who has to go back at 6 weeks. I try and get their, once they're starting to come off of crutches. So we're looking at normalizing gait patterns by that 6 week mark. I will talk to them about what are we averaging and feeling good. So what are we averaging and feeling good? And then similar to a return to run or ramping up someone's running, I would say, all right, percentage wise, let's look at what you're getting per week. I do not expect you, we're not bumping that up by 10,000 next week. Like, we should be at I say 5 to 7% increase. And that tends to go pretty well and gives some of my people who want, like, need numbers, because I've got a lot of those, they need structure. And I'm like, if you're tracking your step goals and your step count, like, we should not be increasing weekly by more than 5 to 7% a week. I find that gets them going in the right direction. If they're going up by 10%, or they have the inevitable day where they went to Disney World and didn't do what I told them to do, and they get that 30,000, I tell them, we're gonna expect pain coming out of that. Like, your joint wasn't ready, we knew that. That doesn't surprise me, doesn't shock me, now we have to deal with it.
Yeah, I can't say I can't say it much better than that, but I think I just let pain be your guide, let fatigue be your guide. I try to tell my patients to keep your discomfort level under a 4 or 5 out of 10. And when you're fatigued, that's your body's way of saying it's time for you to stop.
I actually have an example of that. About 2 weeks ago, one of my patients who was about like 3 weeks post-op, she was like, oh, I don't think I'm moving around that much. And she had like 5,000 steps like in a day. And she was like on crutches, like, and I was like, we need to slow this down a little bit, because she was getting sore. And so I think tracking is extremely helpful early on. Just sometimes they don't realize how much they're moving.
And they're used to moving.
Yeah.
These people who have this surgery, in my opinion, it's an active folk. This is not a lazy injury, typically. These are people who move for their jobs. They are nurses. They are up on their feet. They're marathon runners. They want to. And sometimes I find that giving them an expectation guideline can be really helpful of, like, do not exceed this. It will hurt. And I'm straight up. I'm like, your joint's not ready. You will be in pain if you're getting, like, at that stage, I'm like, dude, 5,000 is a lot. That's a lot. And so I think setting some of those goals and then reading the room on the patient, like, sometimes they don't need that, and we don't have to have that conversation, and that's great. Yeah, go for it.
And then, obviously, as we all know, not every patient is the same. You know, your daily life plays a role in your recovery. So you have 2 patients with the exact same surgery, and their daily life plays a role in how they recover. So for your super active, for example, I have a former therapy technician of mine that she's 8 months out, but she's struggling, but she's super active. But, you know, running a mile for her gets her up to like an 8 out of 10 now. Whereas I have a more sedentary patient who just got discharged, and she killed it. So not everyone is the same in how they recover.
So I see the patient back at 6 weeks, all right? And that talk is sometimes a pep talk, like, you can do this, and sometimes it's a bring it back, slow it down talk, to y'all's point. Going from the 6 week mark on, because a lot of them are feeling too good, I would say, and they say, I'm ready to run. How do you address that next phase? I tell them this is the preparation for impact phase training. I also tell them this is the meat and potatoes. The next 6 weeks is going to determine if you're going to do this or not, for real. What are y'all thoughts?
Yeah, that's when I really look at and assess, like, the endurance of the glute med and the hip stabilizers, and then start getting them on the leg press and looking at, like, strength differences side to side. Because like if it's still pretty different, which it probably is, I mean, it's going to be a lot less, the strength's going to be a lot different for a while. So just educating them on that, it's going to take some time to build this up. It could take another 4 to 6 weeks for that surgically operated hip for the glute med to get close to the other side for safe running and impact. So, and then just kind of, figuring out where they are with that and just working on getting the reps up and their force production up for the glute med.
I'll definitely be looking at their single limb support, duration and quality, their ability to control an 8-inch step up, step down. What is the quality of their squat and the depth of their squat? I'll start them on a jog walk program, assess the quality of the jog, but I'm starting slow, so I'll kind of usually let them start at their own pace, like 1-to-4 ratio typically, but only a couple bouts of that, and then let's see how they return. But I'm not letting them do that on their own right out of the gate.
6 weeks is where you get to start the fun stuff. So where you get to do more of the closed chain loading and get into more single leg loading. So I try and get them pretty excited about that. Like 6 weeks is a pretty exciting time. PT starts to look a little bit more like workout, which they're really excited about. And I start the conversation about running, but a lot of my people are so excited to run again that I'm like, I don't even want to bring that up as an option at 6 weeks or even talk about that. We're gonna really dial in on your strength in your single leg. So like, I love a B stance RDL. I start doing a lot more biased single leg stuff on that side, compare it to the other side. I find, try to avoid a ton of squats. They tend to, everyone loves a squat. They want to get back to squats, but we focus a lot more on the hinging, a lot more on single leg stance engagement, endurance. I mean, they're going to love their bands till the end, baby. But starting to incorporate more weighted movements, heavier movements, and rehab starts to look a lot more fun for them at that stage. And I try and get them really excited about the strength and endurance component of it. And then towards weeks 10, they're hopefully feeling pretty darn good, about to be at the 12-week mark. And that's when I'll start the conversation, and especially actually going back to the step count thing of like, how many steps are we getting, right? You have to be able to perform and tolerate a lot of stepping to even get to run. So where are we from a step count standpoint? Are we hitting 10,000 at that point? Are you back in your normal life at your job? Because that's also a lot of impact and weight bearing. And is your day-to-day, like, if you just went back at 6 weeks, which is early, if you went back at 6 weeks and you're on your feet and you're tolerating that well, sure, maybe 12 weeks we start to talk about that. If you went back early and you're like, I'm achy all day long, I am still achy, we are not talking about running at 12 weeks. Because your day-to-day life involves so much more standing, walking, you're already getting more impact. That's not a conversation that I want to aggressively push early. And I go back to my steak, man. You're still medium rare. This is a long-term thing. Likely you've been in pain for 3, 4, 5 years. Like, it was a long injury leading up to this. Let's think big picture here. You want to run a marathon? Great. I want you to too. It's not going to be in the next 6 months.
So for your active population, do you guys have a favorite go-to aerobic low-impact activity, both in the clinic and outside the clinic?
I mean, I'm usually starting with cycling.
So cycling, and then any aerobic aquatic work or anything like that? Especially with swimmers or anything like that, just even walking, the buoyancy in the water or anything like that. And he said, for those who had the means.
Well, Dr. O, how long do you want them out of the water?
I'll let them go in at 6 weeks if the wounds are well healed. Mm-hmm. Now, if we're having some scabbing or anything, I might give it a couple more weeks or to days, depending. But 6 weeks is usually the cutoff, and I'm usually good with that.
I'm not a huge fan of the elliptical, I'll say that. I think the elliptical tends to be, when they get cleared for the elliptical, they get excited. They're like, oh man, I can overdo that. And they also, I feel, for some reason, separate the treadmill from regular walking. They're like, oh, I can walk again, so I'm gonna get on the treadmill for aerobic exercise. I don't love that. That will ramp you up. Treadmill and elliptical are ones that I'm like, not my favorite. If you tolerate it, great. I'm not gonna recommend it. I love a bike. I think the bike gets their heart rate up, doing some intervals on the bike when you're allowed to add resistance for that as well. Throw some resistance on there, get a little bit more activation without a ton of weight bearing. I personally don't have a ton of experience with pool, so I can't speak on that, but I imagine I would love it if I had that opportunity.
Going back to prior to 6 weeks too, once they go to 50% weight bearing, if you have UBE, then they can stand and do some cardio with their upper body as well, which is good for standing tolerance. And then going to the pool, like they can mimic a lot of the exercises that you're doing in the gym with them closed chain in the water, especially like lateral stepping is really good. They could do squats in the water, things like that. If they can get a like body board, they can do some really gentle like hip extension just to work glutes in there. Just kind of give them some ideas like that. If you feel that they're safe to do that with, but because they can't overdo it in the water. I had one patient who actually was not one of Dr. O's. It was somebody who came down from Fredericksburg to work with me who has EDS, and we tried this, and she went back into the water. So only supposed to go in for 10 minutes, give them boundaries. She was in the water for 45 minutes, and she got flared up, but give them boundaries, say start with maybe 5 to 10 minutes of some work in the water, tell them they're gonna get sore if they overdo it, just like you would with any new exercise, and then let's talk, get feedback, and then kind of advance it from there. Not being able to be in the water with them, I feel, and learning from that patient, don't have as much control, so you have to just start off really small with them in the water, and then as they show that they're advancing through and not getting flared up, then you can, give them more coaching on it as they go.
Okay, 2 more questions.
Do you guys have your favorite objective ways of measuring either isometric strength for the abductors and adductors and glutes to assess if the patient is ready for running? I know you got the leg press strength test, but you guys have some other favorites that to determine if they're really ready?
Again, I'm obviously doing manual muscle testing, but I'm looking from side to side, looking at movement patterns. I'll assess endurance and quality. There's not a specific, I'm not looking at leg press. Yes, I'll look at a leg press, but it's not just one thing that I'm looking at. Sorry, that's not a very specific answer, but I'm looking at a whole gamut of things. So there's not one thing specifically I'm looking at.
Yeah, like Carter said, looking at how much they can do double leg press, how much they can do single leg press, side-by-side comparison, looking at side lying hip abduction strength as well, manual muscle testing. And then if they can get them on an unstable surface like an AirX mat, single leg stance, maybe a 2 or 3 pound weight on the opposite leg, and have them do standing hip abduction with the involved side in stance, and just see how well they can keep pelvic control. And that gives me a lot of insight with those multiple exercises.
I'm a big
Go ahead.
I'm a big side plank girl for trunk control and lateral hip abduction. So if we've worked up to the place where they're no longer doing a modified side plank, they're doing a standard side plank, great trunk control, can maintain that for a solid minute. They're up in their resistance on standing hip abduction, like standing clamshells. They can do resistance for a longer period of time. We've worked that up, and they're doing that with a pretty heavy band on my heavier trunk control ABD exercises, and they're tolerating a good amount of walking and those are kind of mine for this specific one. I actually don't tend to do leg press as my primary for like return to run. I look a lot more on kind of the lateral endurance.
One other thing I will use a lot of is the TRX because it's really hard to cheat with the TRX. So, for example, I don't have a name for it. It's like almost like a reverse, we call it a blast off, but it's like a reverse squat, single leg squat. So it's just making sure that you're not trying to twist out of it when you're going down or coming back up. Shows you a lot about functional strength. Or doing like a warrior 3 position, making sure you're not pivoting out of that. So again, I'm looking more at quality of movement rather than like how strong you are.
For the VCU grads here, you may know the name Blaze Williams. Raise your hand if you know. You guys don't know? Oh, there we go. We got a few. He was a professor there. He put together a really good objective and validated test to see if somebody is actually ready for running. So Google it. It's a really good, just FYI. He put it together. It's pretty tough. A lot of runners fail it actually, and they're running marathons. But anyway, check it out.
Do we have one more? Okay. Okay, 2 more.
I was just going to make a real quick comment about the pool. Talking about doing cardio in the pool, I do use the pool with gait mechanics. I don't have a pool at our facility, but I'll send people to the Y and all that kind of stuff. Putting them in the deeper water, chest level water to work on their mechanics. As they get better with that, have them come down to a little shallow water to work on getting rid of the limp and stuff like that. I know I used it when I tore my ankle up, and that helped me be able to walk again. So just if you have somebody who still has a limp, that's a great way to do it, and they can start with a smaller time on there. Yeah, I usually do 30 minutes, but mine aren't like that. So if you have access to a pool, great job. So.
Specifically for the hypermobile patients, is pelvic floor strengthening ever a consideration to help like stabilize the pelvis?
Yes, 100%. So the more muscle activation that the hypermobile patients can achieve, like while they're doing a movement, the better they're going to feel. Sometimes you have to worry about over tight adductors, so that sometimes they'll get some groin pain because some of those stabilizer muscles are just always like kind of almost like hypertonic, like always on. And so sometimes they'll get a little bit of discomfort if their pelvic floor muscles are actually too tight, but most of the time, like 90% of the time, that is not the case, and you want to have them activate pelvic floor and just work with them on training that, working on even like deep breathing exercises as well. It's really helpful. So.
Any last thoughts?
I can shout it. I was just curious what y'all's personal top 3 exercises are, particularly like moving towards the later end of the stage. It could be 3, 4, 5, whatever your go-tos are.
Okay. The first one that I try to get in as early as I can is prone, kind of like ankle-resisted bilateral abduction. So kind of start with the short range of motion, and then just kind of as they get more comfortable and stronger, they go through further range of motion and just get them burning as much as possible. And then kind of mention like the kind of unstable surface, stance leg on like a AirX mat, kind of working that, and then lateral band walking, things like that.
Early on, one of my go-to exercises is Shirley Sarman exercise. It's just quadruped rocking. The emphasis is on keeping neutral spine all the way through. So turning on glutes, TA, turning off upper rectus, letting the scapula go. I find that's a great way to get everything to kick in, and you teach it right off the bat. I think moving forward, again, like I said, I like to use the TRX because it's really hard to cheat. because I want to make sure, I'm not letting anybody compensate. And then kind of late stage, I like using blaze pods for like that neurocognitive training. I enjoy that a lot.
So I don't want to steal the late stage peeps thunder because they're about to come up here. So I'll try and keep it on like the 6-week and earlier stage. I love a side plank hip abduction holds. Those don't get old. I also repeat, Matt. I love to do prone hip abduction, starting at an isometric with the band, working their way up to where they're doing with their stabilizing side, and then active on their alternative side or their non-surgical side, and then working to doing active flutters kind of in that position or holds. That I really feel gets the glute med well without engaging your hip flexor. So if someone's really having a hard time doing a lot of co-contracting, putting them in prone and just really isolating, starting with that progression works pretty well in the early stages. I love a wall clamshell. It's my favorite thing in the world. Gets them in single leg stance. I start them doing that with both active and isometric on the other side too, contralateral to their post-op side. But those are some of my favorite early ones.
One more I have, quadruped, opposite lower extremity, upper extremity, just an inch off the table, no toes, being able to assist. And then you progress it to being knees on a half roll or a full foam roll. So you're getting that dynamic proprioception.
All right, big round of applause for our panelists. Much appreciated. Great job. Phenomenal.